Hi, everyone. Welcome back to Module 5. This week, we are focused in on pulmonary, the respiratory system. So just to go over last week's Module 4 included common urinary complaints, urinary tract disorders, kidney and bladder disorders. So this week, I'll definitely be doing a review for the quiz, both for the coding quiz as well as the quiz for last week. I'm just waiting for Professor Kavanaugh. We wanted to go over your coding quiz together to make sure we're both in agreement in terms of partial credit for some of your answers, as well as just getting a conceptual idea of where the class is at in terms of their understanding of coding and how it applies to practice. So again, if you haven't watched that coding video in the module with FNP, real world, or whatever she's called, I forgot her name, please go ahead and upload that and watch it. There is a teaching tool in there to practice with as well. Okay, so this week our readings focused around sleep apnea, infectious respiratory disorders, inflammatory respiratory disorders, lung cancer, smoking addiction, bacterial versus viral pneumonia, the common cold, TB, COPD. Your nursing procedures looked at pulmonary function tests, pulmonary stress tests, and X-ray interpretation. Next week, we'll be going much more into depth in terms of chest x-rays and treatment guidelines in terms of COPD and asthma. Okay, those are going to be things we're going to really get into next week. I'll brush over them this week. In your module, under the YouTube supplementary videos, I did upload a couple of videos on x-ray interpretation. Please watch them. They're fantastic videos. It is a systematic process. X-ray interpretation is in of itself an entire class, but we do brush upon it because there are certain things as a nurse practitioner that you are held responsible to be able to interpret. So we will go over those next week for sure. We'll also go into TB treatment more next week as well. We're also going to get into COVID next week as well. Okay, so just to make sure that when you're considering the respiratory system, that you also are remembering and reviewing your normal findings. You want to make sure you're very conscious of vesicular versus bronchial breath sounds. Remember, your upper lobes are where your bronchial sounds, breath sounds are heard, where they're louder, and your lower lobes are where your vesicular breath sounds are heard, where they are soft and low. We want to know the difference between tachypnea, egophony, tactile fremitus, and whispered pectiliquy, where the patient whispers 99 or 1, 2, 3, and you're comparing the lungs, where you're looking for consolidation. You also want to be conscious of your assessment skills in terms of percussion. All right, so we're percussing on the lungs. When it's normal, resonance is heard over normal lung tissue versus tympany or hyperresonance, where we're hearing COPD emphysema, or if empty, the stomach can also be a tympanic type noise. A dull tone with percussion, you would indicate bacterial pneumonia with lobar consolidation, or pleural effusion because you have fluid or a tumor. A solid organ such as the liver sounds dull. So just remember your normal findings in terms of percussion and breath sounds. That'll make it much more clear to understand when you have these abnormal findings in these particular respiratory diseases. Again, so in Module 4, we went over the prostate and penile disorders. We went over common endocrine and metabolic complaints, BPH, prostatitis, hydrocele, and we talked about prostate massage. I just like to review what we've gone through so far, just to give you guys a reminder, like, you know, you're really getting a lot of material put onto you. So just try to keep focused on what exactly we are going over in terms of material. That way, you know where to focus your tests and you're studying for your tests and your exams. All right, so let's get started. So the first thing we're going to talk about is just your basic common respiratory complaints. The cough, you know, a basic complaint would be a cough, and common causes. Obviously, it just clears the airway and clears the airways of secretions and irritants. There's multiple causes for coughs. I put a chart in here of your ACE inhibitors and your ARBs just to remind you that those are also can be common complaints. In terms of managing your basic cough, you're prescribing antitussive, decongestants, antihistamine, expectorants, and of course, you're always talking about smoking cessation. You definitely want to consider your differentials for a cough. There's a lot of different reasons for a cough. Consider different conditions such as your bacterial pneumonia, your postnasal drip, your asthma, GERD, heart failure, pulmonary emboli, lung cancer, and ACE inhibitor use, or ARBs as well. But ACE inhibitors tend to be, very common in people who have hypertension, diabetes, or CKD. Those are the ones we're prescribing. And sometimes they will develop a non-productive cough on these types of medicines. So always look at your patient's medications. A cough usually occurs in about 10% of patients who take those. So just keep that in mind. And keep in mind, when it comes to a cough, a diagnosis can be made about 80% of the time just by taking a thorough history and exploring the details regarding the onset and the nature of the cough with the patient. So you're asking a lot of questions, just like you would with any assessment, but in particular to the cough, you're saying to them, when did the cough first start? What factors may have prompted the cough? Like, did they have a recent respiratory infection, an exposure to any kind of noxious agents, cleaning agents? Was there any initiation of a new medication? Is there a seasonal pattern that comes with this cough? Is it related to work or hobbies? Have they just recently gotten any new pets, new perfumes? Those are the kinds of questions you really want to know. You're also asking, when does the cough usually occur? Is it upon rising, at bedtime, during exercise, or throughout the night? Other things you want to find out: what factors seem to stimulate the cough or make it worse? Has the patient been able to identify any factors that seem to provide relief from the cough, such as sitting upright or avoiding exposure to certain agents? And a big thing that you want to be assessing yourself just from, being present near the patient is, what is the quality of the patient's cough? Is it dry and hacking? Is it wet? Is it raspy? Is it deep? Is it throaty? Is it productive or is it non-productive? If the patient produces sputum with the cough, you want to ask the patient to describe the amount of sputum produced per day. So you can try to get them to estimate, is it like a teaspoon, a tablespoon, or, is their tissue full of sputum, or is it just a little bit? You obviously want to know the color. Is it yellow, gray? Are we looking at brown, green, blood tinged? And definitely asking about the consistency. Is it thick? Is it ropey? Is it frothy? Is it tenacious? When is the cough most productive? And of course, we want to know, does the patient cough more when they're lying supine, or is it constant throughout the day and night? A lot of assessment to do with a cough. And if you do this, significant, if you ask all these questions, you'd be very, very more likely to come up with a clear diagnosis. Okay, so another common respiratory complaint would be dyspnea, which is shortness of breath. Again, we're considering, what is dyspnea to your patient? So it's a perceived sensation that vary among patients. It's atypical presentation in older patients for ischemic heart disease or myocardial infarction. And common causes of dyspnea can be pulmonary, cardiac, hematological, or psychogenic. So in terms of common respiratory complaints, you always want to also consider your danger signals that you would make sure you're ruling out based on your review of systems in your H&P. Remember, you're always focusing your plan of care, ruling out the worst case diagnoses first. You want to get the worst case thing out of the way first to make sure that you're not missing treatment that needs to be done as soon as possible. Especially with certain symptoms, like these worst case scenario symptoms, when you hear like blood loss, pain, significant sudden pain, or significant sudden weight loss, these three things are always red flags that something bigger is going on, and they're always a priority in diagnostics in your plan of care. So you want to consider in your differential diagnoses, and you want to rule out as soon as possible things like COVID-19, lung cancer, acute carbon monoxide poisoning, a pulmonary emboli, and definitely, any kind of impending respiratory failure, such as an asthmatic exacerbation. Another thing I wanted to point out is that I want you to consider your own experience and knowledge of what the deathly dying patient looks like. I mean, I'm sure a lot of you have seen patients at a point where you're like, oh no, this patient is on his way out, meaning he's in distress. So these are things to be in tune with and not to ignore. Like if you're getting an intuitive feeling that a patient is declining quickly and you can see it's about to happen, please make moves, call 911, get treatment in place immediately for this patient. In terms of dyspnea, in the majority of cases, dyspnea is a result of cardiac or pulmonary decompensation. There are several symptoms associated with dyspnea, such as tachypnea, rapid breathing, orthopnea, which is dyspnea relieved in a seated or upright position, and paroxysmal nocturnal dyspnea, which is sudden episodes of acute dyspnea at night. The causes of dyspnea are often very complex. So the common causes and precipitants of dyspnea are pretty consistent though in terms of diagnoses. So things you would want to be aware of, like in terms of pulmonary concerns that would lead to dyspnea would be COPD, asthma, parenchymal disease, interstitial lung disease, pulmonary hypertension, and morbid obesity and an extensive pleural effusion can also be a reason for pulmonary dyspnea. Cardiac dyspnea is more associated with CHF, pulmonary venous congestion like mitral stenosis and mitral regurg. And then hematological dyspnea would include severe chronic anemia. And then your psychogenic dyspnea or shortness of breath, that's because of psychological causes, would be mostly around anxiety and panic disorders. Dyspnea can be acute or chronic, and patients with COPD may have both acute and chronic dyspnea. It's really important when you have these patients with dyspnea that you do a complete workup to determine the underlying cause of dyspnea so that appropriate treatment can be initiated. Dyspnea caused by acute anxiety may mimic cardiopulmonary decompensation, and patients with pulmonary hypertension may have episodes that resemble anxiety-related dyspnea. So these are things to be aware of. Okay, hemoptysis. So another common respiratory complaint is hemoptysis or expectoration of blood. So of course, in terms about 80%, excuse me, about 80% of hemoptysis cases are related to inflammatory causes such as bronchitis, bronchiectasis, pneumonia, and TB. So in terms of the management of hemoptysis, obviously, if we have a massive amount of hemoptysis or a massive amount of expectoration of blood, we need immediate treatment, surgery, or bronchoscopy. Prevention of aspiration and keeping the airway open are of the utmost importance, and they may need to be intubated, intubated because they need their airway kept open. Supplemental oxygen and replacement of the blood loss obviously may be necessary depending on the patient's blood pressure, pulse, ABG results, and their hemoglobin. The treatment of chronic hemoptysis is directed towards the underlying cause. When the cause is inflammation, as it is in chronic bronchitis, TB, and bronchiectasis, the patient has to be educated that they have to stop smoking. They need to comply with their prescribed meds, like their antibiotics, bronchodilators. They're educated on how to perform deep breathing and coughing exercises every couple of hours regularly, and to avoid exposure to secondhand smoke. In terms of teaching the deep breathing and coughing, that's obviously if they the bleeding has subsided. Education of the patient and family regarding the causes of hemoptysis is really important. You want to educate them on how it can be prevented. And of course, if they need to be taught to notify you if they have any change in the color, amount, or consistency of the blood that's expectorated. Any sudden increase in the volume of blood expectorated or change in the character of the hemoptysis should be reported immediately. If not, they should just immediately go call 911. Okay, sleep apnea. We're going to actually get a lot more into this in the next class, but I did want to kind of just go over the basics of it. So the epidemiology and causes of sleep apnea are unrecognized, and untreated obstructive sleep apnea is estimated to be 30% in adult male population and 15% in the adult female population. There are different sleep stages and different types of sleep apnea. Sleep apnea is defined as a temporary pause in breathing during sleep that lasts about 10 seconds, For a confirmed diagnosis, this has to happen at a minimum of 5 times per hour. So for the patient to be diagnosed with sleep apnea, which is done via a sleep study, they have to have a pause in their breathing during sleep that lasts at least 10 seconds, which occurs a minimum of 5 times an hour. The 3 patterns of sleep apnea are central, obstructive, and mixed. Central sleep apnea occurs when both the airflow and respiratory efforts are absent. Central apneas are a result of the absence of neural output from the brainstem's respiratory control system, which leads to a lack of inspiratory effort. The respiratory center in the brain fails to respond to elevated carbon dioxide concentrations. And in contrast, during obstructive sleep apnea, respiratory efforts persist, although airflow is absent at the nose and mouth. Airflow obstruction occurs when the tongue and the soft palate fall backward and partially or completely obstruct the pharynx. Many adult patients exhibit actually both mixed apneas, in which both central and obstructive patterns occur. So again, these patients are going for sleep studies to get their diagnoses confirmed. The diagnostic tests are done with these scales with an overnight polysomnogram and a multiple sleep latency test. So in terms of management, we want to definitely eliminate the risk factors and get the patient set up with devices that will maintain their upper airway patency. Maybe they're going to need a mouth guard or an oral appliance, as well as the possibility of surgery if it is very severe. So here are some things I wanted to just talk about, and I'll get back into this next time, but I definitely wanted to make mention of, if the sleep apnea is not treated, there are definitely consequences, and some of the consequences include pulmonary hypertension, cardiac dysrhythmias, ventricular failure, ventricular hypertrophy, MI, an increased risk for an MI, increased risk for a stroke, and nocturnal angina. So it definitely has some long-term effects if this is left untreated. Obesity is a big risk factor for it. So, you're definitely looking at your patients that have an elevated BMI and really considering them to need to rule that out if they are having any issues with sleeping. So follow-up and referral, you're going to educate the patient on how to use their CPAP machine. You're going to definitely do counseling. You want to follow up to do the detection of the small airway disease, which may be difficult in OSA patients. And you definitely want to do a referral for an investigation of both COPD and sleep apnea. So the thing I wanted to mention with these patients is in terms of education, you want to make sure these patients are actually using their CPAP and they're using it correctly. Because a lot of the times when I worked in home care, I would find that they would get all set up with their machines. The respiratory therapist would come out, set it up for them. And then within 2 days, number one, either they hated it, they don't like using it, they can't stand the mask on their face, or the machine is just not connected correctly, or whatever the case may be. So the follow-up is really, really important. You want to make sure they have a good connection with the surgical supply store that provided it, or pharmacy that provided it, so that they have a connection with the respiratory therapist consistently to make sure that their settings are appropriate and they're using their machine and it's functioning appropriately. Keep in mind also the settings and the functions of those machines need to be adjusted if the patient does lose weight. So those are things to keep in mind to make sure to educate your patient on. The other big thing in terms of sleep apnea, diagnosing it and even becoming aware of it in the patient, it usually comes from complaints with the patient's spouse. Patient spouses are the ones who usually notice that the patient is not breathing at night or stops breathing, or the snoring is excessively loud, or whatever the case may be. So keep in mind that if a patient's spouse is saying that, a lot of the times the patient or the male patient will kind of try to shush their wife and say, don't, and make sure that you actually follow up with that and talk about how important it is for follow-up. Okay, let's get into infectious respiratory disorders. We're going to start with upper respiratory infections. Bacterial infections are the cause of 25% of the cases, and the pathophysiology of upper respiratory infections includes the common cold and flu. In terms of management of upper respiratory infections, we usually treat with antibiotics, cough suppressants, rest, antivirals, fluids, and antipyretics, depending on the symptoms presented. So your common cold would be considered your upper viral respiratory infection. Upper respiratory infections include some of the most common infectious diseases and account for millions of visits to healthcare providers annually. Most upper respiratory infections are caused by viruses. Bacteria causes about 25% of the cases, as I said before. For the average adult, upper respiratory infections are a source of discomfort and disability and loss of productivity. But more importantly, for young children, the immunocompromised, and older adults, these infections may be a cause of a morbidity and or serious illness. So as you know, with these patients, in children and older adults, as well as adults with underlying respiratory diseases, viral upper respiratory infections are frequently complicated by bacterial superinfections. So just keep that in mind. You could get both, double whammy, in your already immunocompromised patients. Influenza or the flu and the common cold, also known as viral rhinitis or acute coryza. And make sure you know that. I know that sounds ridiculous, but try to remember, like, the name of the common cold is referred to as viral rhinitis or acute coryza, because they do refer to the cold, a common cold like that on the boards. Like they will refer to a cold as acute coryza, like, these fancy words for an upper respiratory infection. So influenza, the common cold, and acute laryngitis are some of the more frequently occurring upper respiratory infections that you will need to manage when you're in practice. Children younger than the age of 5 are the most commonly affected, and on average, children have approximately 3 to 8 upper respiratory infections per year. Adolescents and adults about 2 to 4 per year, and people older than 65 have fewer than 1 per year. Most upper respiratory infections are viral in origin. And the most common agents are caused by the rhinoviruses. The most common agents are rhinoviruses, coronaviruses, adenoviruses, and Coxsackie viruses. For upper respiratory infections caused by bacteria, the agents are similar to those that would cause otitis media. So in decreasing order, they include Streptococcus pneumoniae, Haemophilus influenza, Moraxella cotorellus, and Staphylococcus aureus. Infections such as acute infections such as acute epiglottitis and respiratory syncytovirus infection occur predominantly in infants and younger children, but may occur as life-threatening infections in adults. RSV infection can cause severe pneumonia and other lower respiratory tract diseases in older institutionalized patients with suppressed immune systems. Acute epiglottitis, a bacterial infection, can result in complete or partial airway obstruction. Okay, so very important. The book doesn't go that much into acute epiglottitis, but when I was in school, they made a big deal about it. And I realized in practice how important it is just to make you guys aware of what that is. Acute epiglottitis is just a sudden inflammation of your vocal cords. It's very, very serious. It happens very suddenly. And it can be, it sounds like somebody has a mouthful of potatoes, like they suddenly are having, like their sound like their mouth is filled with potatoes, like they can't talk straight. When you hear that, you call 911, and you want to make sure to try to keep this airway open, so they will need to be intubated. Here is a lot of information about that. It's life-threatening. Okay, so again, this is an emergency situation. It should be suspected in adults when they have pain on swallowing, and they are drooling, or they have shortness of breath and stridor. So it's very rapidly progressing cellulitis of the epiglottis, and that may cause a complete airway obstruction. It begins as a cellulitis between the tongue and the epiglottis, and then the epiglottis is pushed posteriorly as it becomes more swollen, and that's how it blocks the airway. It's more common in severe and young children, but it can occur in older, younger children or adults, and it's something to be more aware of, especially now with COVID, because it is a respiratory, it's induced by respiratory illness, and it can lead to that. So you never want to try to view the epiglottitis with a tongue blade, because if you could actually cause more of an airway obstruction, because it could cause a spasm to the larynx if you try to tickle it if you get in there with the tongue blade. So you want to just transport them immediately to the emergency room and let them, be put immediately for surgery, because they'll need to be sitting up for visualization with the laryngoscope to make sure that they can get good airway control. They will require hospitalization and IV antibiotics and close monitoring of the airway to prevent them from going into respiratory distress again. All right. So remember, that's just worst case scenario in terms of a respiratory infection, upper respiratory infection, acute epiglottitis. Okay, so back to the common colds. So in terms of the common cold, again, it's self-limiting. It can be for 4 to 10 days. It's most contagious from days 2 to 3. It's transmitted by respiratory droplets and fomites. Usually these patients have an acute onset of fever, sore throat, frequent sneezing in the early phase, accompanied by nasal congestion, runny nose, and rhinorrhea of clear mucus. Or remember, clear mucus is coryza. That's what that word is, coryza, C-O-R-Y-Z-A. The patient may complain of a headache, but usually a classic case of a common cold, has a spontaneous resolution within about 4 to 10 days. When you're looking at these patients in terms of physical assessment, their nasal terminates are usually swollen with clear mucus. They may also have a blocked tympanic membrane. Their anterior pharynx is reddened, their cervical nodes are smooth and mobile, and their lungs usually are clear. They should be clear. Differential diagnosis that you would want to consider in terms of a common cold includes allergic rhinitis, group A streptococcal pharyngitis, bacterial sinusitis, atypical mycoplasma pneumonia, infectious mononucleosis, and possibly mumps, rubella, and cytomegalovirus. You want to make sure you're paying close attention to any epidemiological patterns in terms of like any current outbreaks in the community. That's very important. So this is where you're definitely keeping close contact with your CDC or local health department in determining the type of disease outbreak in your area. Keep in mind also, if there is any kind of local outbreak or anything important, a lot of the times because you're registered with the health department where you work, because of your licensure, you will get emails of local things that are going on. So you will be kept abreast via email from your local health department. Also, in terms of your guidelines to differentiate cold or flu, the CDC is on top of that. So you're always going to want to keep abreast of what CDC recommendations and guidelines are posted for the current season. Because this is, again, where you're looking for evidence-based guidelines to differentiate your diagnosis and your treatment plan. The CDC offers a tool like this to differentiate symptoms of a cold versus a flu. And these are the kinds of tools you will want to have in your practice, not only to guide your nurses and practitioners, but also to help educate your patients of what they need to be looking for with themselves, their family members, and when they need to, call for help or further follow-up. Okay, pneumonia. So pneumonia, epidemiology and causes, we have CAP pneumonia or community-acquired pneumonia, nosocomial pneumonia. These happen in very vulnerable populations. Diagnostic reasoning includes a chest X-ray, leukocyte count, and a sputum gland stain. In terms of management, we're prescribing antimicrobial therapy, and we're also looking at the Infectious Diseases Society of America for guidelines in terms of treatment guidelines. Next week, when we do focus on chest X-rays, we are going to be looking at chest X-rays of patients with pneumonia, because keep in mind on the boards, you do get films where they're questioning what you're looking at in terms of an X-ray. So you will need to be able to recognize what pneumonia looks like on a chest X-ray. So again, please look at those videos that are posted. Just keep in mind, I know it looks like I uploaded the same video 3 or 4 times within the module. That's not the case. Unfortunately, I don't know what's going on with, anytime I post a video, it seems to duplicate it. So I'm working with Goodwin Technology to try to see if they can fix that, just so you know. So pneumonia is typically an acute inflammation of the lung parenchyma, and it's usually infectious in origin. The lung tissue typically becomes consolidated as alveoli fill with exudate. Gas exchange is impaired and blood is shunted around the non-functional alveoli. The timely diagnosis and appropriate management of pneumonia in patients is critical because of the morbidity associated with bacterial etiologies, as well as the increased mortality among older patients and those with underlying pulmonary disease. Community-acquired pneumonia, or CAP, occurs outside the hospital or is diagnosed within 2 days after hospitalization in a patient who has not resided in a long-term facility for 2 weeks or more before the onset of symptoms. So that's very important to realize that in terms of diagnosing community-acquired pneumonia. Remember, CAP or CAP pneumonia occurs outside the hospital or is diagnosed within 2 days after hospitalization in a patient who has not resided in a long-term care facility for 2 weeks or more before the onset of symptoms. So they don't count being in a long-term care facility as being in the community. So just keep that in mind. So the bacteria causing most deaths in outpatients or CAP pneumonia is S. pneumoniae, which is gram-positive, and it's the most common cause of a focal infiltrate on a chest X-ray. So with the different types of pneumonia, just keep in mind between the Streptococcus pneumoniae or CAP pneumonia, that type of pneumonia has an acute onset with high fever and chills, a productive cough, and a large amount of green to rust-colored sputum with crackles, and their leukocyte, their CBC shows leukocytosis and elevated neutrophils. Versus atypical pneumonia, which is Mycoplasma pneumoniae, that chest X-ray reveals lobar infiltrates, and it has more of a gradual onset with a low-grade fever, a headache, a sore throat, wheezing, a rash, sometimes. So again, in terms of risk factors for and pathogens in community-acquired pneumonia, these are risk factors to consider in your patients, which puts them at higher risk for community-acquired pneumonia. So obviously alcoholism, if they've had any issues with aspiration, your patients that have difficulty swallowing are at high risk for CAP. Chronic obstructive pulmonary disease or smokers, any COPDers or smokers, very high risk for CAP. Exposure to bat or bird droppings. So bird droppings, keep in mind, people have birds and they are filthy. They are filthy animals that require an enormous amount of cleaning. Unfortunately, your elderly patients a lot of the times cannot keep up with the amount of cleaning that birds require. There's a lot of dander that flies in the air, and unfortunately, if they have birds in the house, they are at extremely high risk for CIP. So ask about pets with your patients, please, especially your immunocompromised. They need to consider getting rid of the birds. The birds are unbelievably dirty. You have to clean a lot with birds. Exposure to farm animals or feral cats, that can definitely be risk factors. HIV, long-term travel on a ship, those are risk factors for CAP, lung abscess, and then of course any travel outside of the country. Okay, so let's make sure we clarify atypical pneumonia or bacterial pneumonia versus viral pneumonia. So keep in mind, there's a lot of names for this. So bacterial, atypical, this all used to be called walking pneumonia versus viral pneumonia, okay? We want to recognize the presentation of bacterial versus atypical pneumonia. Actually, meant to say recognize the presentation of atypical versus viral pneumonia, excuse me. So atypical pneumonia is infection of the lungs caused by an atypical bacteria, and it's also known as walking pneumonia, okay? So try not, remember that. Atypical pneumonia, bacterial, walking pneumonia, it's all the same, okay? The two top CAP, remember community-acquired bacteria pneumonia is S. pneumoniae and H. influenzae versus an atypical pneumonia or bacterial pneumonia or walking pneumonia. Sorry, I don't mean to confuse you, but I want to make sure that's clear. The M. pneumoniae and chlamydia pneumoniae are the two top bacteria you'll see in your atypical pneumonia. I like to use walking pneumonia to remember to differentiate those two types of pneumonia, just because walking pneumonia just makes more sense to me, that it'll be more of an insidious slow onset, because if you're walking around with pneumonia, yes, you are sick, but you're not as sick as you would be instantaneously with CAP type pneumonia. So although the pneumonias may be classified as two syndromes, typical and atypical, according to the clinical presentation, they are very similar. However, the characteristics of the clinical manifestations do have some diagnostic value. So typical pneumonia syndrome is that which is seen in pneumococcal pneumonia as well as pneumonia caused by H. influenza and S. aureus. The syndrome is characterized by a sudden onset of fever, cough, chest pain, and fatigue, which is what you normally see in pneumonia patients. However, generally patients with productive cough are more likely to have a bacterial infection. So keep that in mind. Productive cough is most likely due to a bacterial infection. Their pneumococcal pneumonia produce sputum that has a characteristic rusty color, which also could be with purulent sputum, but you're definitely going to see rusty color. Atypical pneumonia is more characterized by a gradual onset of a dry hacking cough, fever, and prominence of constitutional symptoms like a pounding headache, a sore throat, shaking, chills, and myalgia. I myself have had atypical pneumonia or walking pneumonia. Oh boy, it's unbelievable how sick you are and you don't even realize, while you're trying to go. It's amazing. You can just keep going, but still be that sick. So I have a chart in the next slide I want to show you just to help differentiate. So here we have atypical or walking pneumonia versus viral pneumonia. And here you can differentiate the variables to distinguish between viral and pneumonia and bacterial. So remember, viral or walking pneumonia tends to be slow onset versus bacterial is a rapid onset. Clinical profile with bacterial, you're going to have a high fever and tachypnea versus viral, you're going to just have rhinitis and wheezing. And in bacterial, you're going to get a rapid response to antibiotic treatment versus viral, it's going to take longer. And this is, whether it's viral pneumonia or viral anything, that, this is pretty typical of a virus versus bacterial causes of it in terms of presentation and how they respond to treatment. Okay, next we're going to talk about tuberculosis. Again, this we'll get into more next week in terms of treatment, because there's quite a bit of treatment that goes on with this. But just keep in mind, tuberculosis is one of the oldest human diseases, also known as TB. It is an infectious disease most frequently caused by M. tuberculosis in humans. In the early writings, in historical writings, TB was called the consumption because of its tendency to produce great wasting in its victims. During the 18th and 19th centuries, it was known as the White Plague. TB is the leading cause of death worldwide from any single infectious agent, and the pandemic of HIV infection and the emergence of drug-resistant TB strains have worsened the global problem of TB. 1/3 of the world's population is infected with tuberculosis, although not everyone infected with the mycobacterial will become ill. Two conditions exist with tuberculosis, so you really need to know this. Two conditions exist. There's latent TB infection, or LTBI, and active TB. Active TB may be a primary infection or a secondary reactivation. Individuals with LTBI or latent TB infection who become immunocompromised may progress to active TB. So the big thing with tuberculosis is patient education. Patient education, patient education. It's such a big deal. The health department gets involved when a patient is diagnosed with TB, because they literally have to manage the patient's medications and make sure that patient is completely taking their treatment as prescribed. The necessity of educating the patient and the family about the disease treatment and importance of completing the recommended treatment regimen is critical to the management of TB. The patient and the family should understand the information and continue to be provided with reinforcement and encouragement throughout the course of therapy. Patients should be offered the option of participating in DOT For patients who are administering their own medications, strategies that may be helpful for improving adherence include the use of a weekly pill dispenser, and just making sure that somebody is assisting them with taking the pills as they're prescribed. So patients are typically considered to be infectious for about 2 to 3 weeks after initiation of this drug therapy. They have to be instructed on how to control the spread of the the bacilli in microdroplets by using good hygienic measures, appropriate ventilation, and avoiding close contact with family and friends. Patients need to sleep in a separate room until they are no longer considered infectious. And if the patient with TB is hospitalized, they are kept in an isolated negative airflow room even after the treatment is started, until their sputum smears consistently test negative for mycobacteria. They need to make sure to cover their mouths when they cough specifically, and they need lots of fans and keeping their windows open to keep the air fresh in the house, because those droplets are what spread TB, and it's very contagious. There are excellent TB control strategies available to the public from the CDC. Many patients access these guidelines. You're going to definitely refer your patient to the cdc.gov to get these guidelines and make sure that they understand them. However, as much as it's treatable, there are problems of the multi-drug resistant TB, and the issues of compliance with therapy among all population remain a significant challenge for the healthcare providers. Big time. We'll get into the treatment plan of TB next week. Please make sure that you review TB and the induration. Make sure you memorize the criteria for the 5 mm and 10 mm results in terms of TB testing. Super important. You're going to need to know that for your test, your exam. And in terms of the 5 mm and 10 mm results, that's called your Mantox test, and it's looking at the induration, the level of induration, to determine if the patient's PPD result is positive or negative for TB. So just make sure you review that in your text. We'll go over it next week as well. Okay, asthma. Okay, so asthma has 3 principal triggers: allergens and environmental factors, infections, and psychological factors. Management is a very stepwise approach. We're going to definitely go into those treatment recommendations next week, but I'm definitely going to review with you the importance of looking at that process and making sure that you're aware of that is a process in order of treating and diagnosing and treating asthma, because it's a constant evaluation with your asthmatics, because they're constantly changing depending on life situation and triggers. So you have to make sure you understand the stepwise approach so you know how to approach your patient with treatment. So asthma is a chronic inflammatory obstructive disease of the airways. It may occur at any age and may be characterized by wheezing due to airway spasms, tightness in the chest, breathlessness, and cough. The severity of asthma is highly unpredictable, ranging from mild attacks to complete airway obstruction and death. Many pediatricians use the same term, reactive airway disease, because the term asthma carries a negative connotation for some patients. Although reactive airway disease sounds pretty negative to me too, so I'm not sure why that sounds better than asthma. But anyway, although the pathophysiology of asthma is multifactorial and involves many inflammatory pathways, from a practical perspective, 3 principal triggers for exacerbations of asthma have been identified as listed here. In terms of your allergens and environmental factors, we're considering things like inhaled substances such as mold, pollen, dust, animal dander, like I was mentioning before about birds, cosmetics like sprays, perfumes, and tobacco smoke, food additives with sulfite preservative agents, and medications like beta blockers or aspirin and aspirin-containing drugs also can be possible triggers. In terms of infections, obviously upper respiratory tract infections like colds are the common precursors to asthma attacks, particularly with viral infections. Psychological factors are stressful events, or crises can often precipitate an asthma attack. In terms of patient education, you definitely want to educate your patient about reasonable expectations including potential triggers that might be removed and problematic areas such as treatment of noncompliance or improper use of inhalants. You also want to talk to these patients specifically about the cleanliness of their home, vacuuming, sweeping daily, especially the bedroom. Keep in mind you spend the most amount of time in your bedroom, and that's where you sleep. So you want that room super clean, especially free of dust, free of dander, and your sheets clean as well, because pillows hold a lot of dust as well. So those are the kinds of things you're definitely educating your patient on. Other things you want to make sure you're educating them on is when and how to use a short-acting inhaler before exercising. Some patients may only have exercise-induced asthma. You want to make sure you educate them on how to recognize early symptoms of an exacerbation and how to initiate a predetermined plan of action. So the plan of action is strategic planning and way you're treating your patients. You're going to be doing this and educating them on this plan with them, because they need to understand what their next step is too when they're on their own and they're suddenly having an asthma attack. So if they have a plan already in their head, like they won't freak out, and then hopefully they won't freak out in the midst of their inability to breathe and know what to do next. You need to educate your patient on the role of the medications, the long-acting controller versus the short-term rescue therapy, and the critical role for an anti-inflammatory controller medication regimen to reduce the rate of attacks. Again, we're talking to them about proper inhaler use, including the use of space inhalers, a daily peak flow meter for monitoring, especially if they have more moderate or severe persistent asthma. And then, of course, if they need a nebulizer, if they can't take adequate breaths on their own, a nebulizer is definitely an option. And then you also want to reinforce the importance of getting their annual pneumonia and influenza vaccinations. Okay, so we'll go into the treatment plan for asthma next week, but please make sure you're reviewing your SABAs versus your LABAs. In your text, there's a whole nice chart in there about the different, when you would use your long-acting versus your short-acting inhalers. And you want to really review your stepwise approach in terms of the 5 steps for treating asthma. And keep in mind your global initiative for asthma management and prevention. That's also something you want to look at, that's in your textbook as well. We'll review all of that next week, but please make sure you're familiar with it. Okay, next, getting into chronic bronchitis and emphysema, or COPD, more inflammatory respiratory disorders. So chronic bronchitis and emphysema are considered COPD. So remember, COPD is like an umbrella term. So chronic bronchitis and emphysema fall under COPD, but there are 2 main forms of the lung disease. We have obstructive and we have restrictive. Obstructive lung diseases are those in which the expiratory flow rate is impaired, and restrictive are lung diseases in which the lung volumes are reduced due to musculoskeletal disorders, tumors, lung resection, or interstitial lung disease. Obstructive lung diseases are further classified as reversible, such as asthma, or irreversible, such as chronic bronchitis and emphysema, aka COPD. The American Thoracic Society has defined chronic bronchitis as a clinical disorder characterized by excessive mucus secretion in the bronchial tree. It is manifested by chronic or recurrent cough, present on most days for a minimum of 3 months of the year or for at least 2 successive years. In addition, dyspnea with or without wheezing is present. Whereas more than 16 million Americans have been diagnosed with COPD, an equal number are probably afflicted but not diagnosed. So remember, like I just said, chronic bronchitis and emphysema are grouped together as COPD. So when you hear the word COPD or chronic obstructive pulmonary disease, the 2 things you're going to think of are chronic bronchitis and emphysema. The ATS defines COPD as a disease state characterized by the presence of airflow obstruction due to chronic bronchitis or emphysema. Asthma is not classified as COPD, but is sometimes referred to as a reversible obstructive condition, whereas emphysema is irreversible. So keep that in mind. Asthma can be reversible, but emphysema is not. Chronic bronchitis is usually irreversible, but it may be partially partially reversible if there is a bronchospastic component and a significant response to the bronchodilators. So keep in mind, COPD is the third leading cause of death in the US and the fourth leading cause of disability. There are more than 134,000 deaths annually due to COPD, and 52% of persons with COPD are women. The direct estimated medical costs of COPD annually are more than $29.5 billion, which is why it's so important that we prevent and put into place interventions aimed at early diagnosis and delaying disease progression. So keep in mind your risk factors for COPD are your age, cigarette smoking, reduced lung function, occupational exposures, air pollution, of course, alcohol intake. Cigarette smoking is responsible for 80 to 90% of the cases of COPD, and it is also the risk factor most amenable to modification for preventing or delaying the development of COPD. So keep that in mind, so important. That's why we need to get into smoking cessation big time. And please note in your module, there is an article about smoking cessation that I need you to read. It's from the United States USPSTF interventions for smoking cessation. So it's the US Task Force guidelines on how, as practitioners, we are to educate our patients on smoking cessation. So please make sure you read that. There will be questions on your next quiz from that article. Okay, interstitial lung disease, another classification that falls under the respiratory disorders. So ILD, or interstitial lung disease, encompasses nearly 200 clinical disorders that affect the epithelium, the endothelium, or both cell surfaces of alveolar wall and satellite structures, including the terminal and respiratory bronchioles. The term pulmonary fibrosis is also applied to these diseases because fibrosis of the lung is the ultimate result of ILD. So when you think of ILD, you're thinking of pulmonary fibrosis. ILD, or interstitial lung diseases, have many common features, including the similarity of patient symptoms, comparable appearance of chest X-ray films. 4 infections may be associated with the cause or the onset of most of the various diseases, including disseminated fungus, disseminated mycobacteria, pneumocystitis pneumonia, and certain viruses. So generally, interstitial lung diseases are classified according to the type of agent that caused the lung injury. About 1/3 of patients with ILD have an identifiable agent responsible for inducing lung injury. However, the large majority of patients have disease attributable to no known cause. So therefore, the ILDs are classified as those with a known cause and those with an unknown etiology. Each of these groups is further subclassified according to the presence or absence of granulomas in the interstitial or vascular areas. Again, we will get into ILD more next week in terms of treatment. But in terms of basic management, initially you would start corticosteroids, and then after that they would get immunosuppressive therapy, and if necessary, a lung transplant. So lung cancer. Lung cancer is the leading cause of death in the United States and accounts for 27% of all cancer deaths. The diagnosis of lung cancer is typically made when a tumor is seen on a routine preoperative chest X-ray or work physical chest X-ray. So they're getting random chest X-rays, and all of a sudden that's when the tumor is found. Approximately 3/4 of patients have a cough, which may be productive with bloody or rust-colored sputum. There are 4 histological types of lung cancer. The first one is squamous cell epidermoid carcinoma. Then there's small cell or oat cell carcinoma. Then you have large cell carcinoma, which includes giant cell and clear cell carcinoma. And then you have number 4, adenocarcinoma. Squamous cell carcinoma is named for the resemblance of the cells to the epidermis of the skin. These cells usually contain the skin protein keratin. Squamous cell carcinomas arise most often from the bronchial lining and may grow to obstruct air passages. Adenocarcinomas, the most prevalent carcinoma of the lung in both sexes, resembles poorly formed glandular tissue. It may be difficult to determine whether an adenocarcinoma is a primary lung cancer or a metastatic tumor from elsewhere in the body. 55% to 60% of adenocarcinomas are located in the periphery of the lung and are not obviously related to any bronchus. Many organs in the body can develop adenocarcinomas that may metastasize to the lungs. Large cell carcinomas, also called undifferentiated carcinomas, are characterized by a collection of poorly formed large cells that have an abundant cytoplasm. So small cell lung carcinomas tend to grow very rapidly and usually metastasize to distant tissue while the tumor is quite small. The clinical effect of small cell lung carcinomas is much different from that of the other three forms of lung cancer, which is why lung cancers are usually classified in terms of small cell carcinomas or and non-small cell lung carcinomas. Again, because the lung area is so large, tumors can go undetected for some time. Early symptoms such as coughing and fatigue are nonspecific, and patients often attribute these symptoms to causes other than lung cancer. For these reasons, early stage lung cancer, stages 1 and 2, are difficult to detect, and most patients aren't diagnosed until stages 3 and 4. It's important that you review the staging of the lung cancer because there will be questions on your exam, your midterm exam, as well as your boards regarding lung cancer and its staging. I did put in a video also in the supplementary videos in your module that goes over staging, so please review that. We will review that too next week as well in terms of staging, actually. For lung cancer, we're going to talk about staging and treatment. Okay, so keep in mind there are 3 types of SCLC or small carcinoma lung cancer, and you should be able to differentiate the 3 of those. Okay. And of course, in terms of the epidemiology and causes, it's relatively resistant to current therapeutics. Smoking and occupational and environmental exposure obviously should be removed as much as possible. So clinical manifestations of lung cancer depend on the location of the tumor and the extent of the spread. Up to 25% of patients are asymptomatic at the time of diagnosis. However, if present, symptoms can be divided into 4 categories. We have intrathoracic or local, which are regional symptoms. We have non-specific systemic symptoms. We have symptoms resulting from extrathoracic involvement, and then we have paraneoplastic syndromes. In your text under table 32.3, they present a summary of the clinical manifestations of lung cancer, so you should definitely look at that. So diagnostic reasoning, follow-ups that you're going to be ordering in terms of getting this patient situated, and of course you're going to be referring him to an oncologist at this point. But once these diagnoses are made, you're going to need to make sure you're following up, that the patient is consistently following up with their oncologist, and then you're going to want to just read the consultations that the oncologist is recommending for your patient, so you can go ahead and provide the patient with some extra support and education. In terms of diagnostics, you're ordering a CBC, BMP, a hepatic panel, coagulation studies, a chest X-ray, a chest CT with contrast. They may need a video-assisted thoracoscopic surgery. Again, that's up to the oncologist. You know, you're going to be making referrals at this point. It's just important for you to know what the treatment plan would include, so you know how to give your patient the heads up. So keep in mind, aging and advancing age are definitely one of the most common risk factors for any type of cancer. But the cancer with the highest mortality rate is lung and bronchial cancer in both genders. So just keep that in mind. And again, I can't stress enough, the most common risk factor is smoking. So please make sure you do your due diligence and discuss smoking cessation with every single patient at every single visit, any of your smokers. So management of lung cancer obviously is preventative, and then we get into chemotherapy, radiation, and surgery as needed. They could have a pneumonectomy or a lobectomy. Again, we'll dive further into the treatment options. In terms of screening for these patients, again, remember, we're following our guidelines. So what are our evidence-based guidelines from our U.S. Preventative Services Task Force, or the USPSTF? I know I keep bringing that up pretty much in every module, because you have to remember that's who you're going back to for your guidelines in terms of the expectations of what you're providing for your patients. So the USPSTF recommends annual screening for lung cancer in adults ages 55 to 80 who have had at least a 30-pack a year of smoking history and currently smoke or have quit within the past 15 years. The screening test is a low-dose computed tomography. Again, so these are the patients that the USPSTF recommends that we do an annual screening for. These are adults 55 to 80 who have at least a 30-pack a year smoking history and currently smoke or have quit within the last 15 years. These are the patients you're annually screening. That insurance will cover because it is under the guidelines. Okay, so because of this horrible mortality rate with lung cancer, we now need to definitely talk about smoking addiction and the importance of educating our patients on quitting. So the epidemiology and causes: smokeless tobacco, electronic cigarettes, and the tobacco industry. Now we have the e-cigarettes as well as vaping. So keep in mind right now, this is actually getting worse more than it's probably getting better. So keep in mind, when the smoker smokes, they are ingesting 4,000 chemicals and gases inhaled directly into the lung. Nicotine usage effects can affect the central nervous system, the cardiovascular system, and the respiratory system. Tobacco use is the leading preventable cause of disease, disability, and death in the US, particularly from cardiovascular disease, cancer, and lung diseases. In your textbook, table 33.1 lists the effects of cigarette smoke on the cardiovascular and respiratory system. Please review that. Cigarettes are responsible for 1 in every 5 deaths in the US, and in the United States, 8.6 million people have a serious illness caused by smoking. It's terrible. So there are obviously also significant hazards for non-smokers who breathe the smoke of other cigarettes. So just keep that in mind too. You want to educate your patients to try to stay away from their kids, especially babies, if they are still smoking in the house. Diagnostic reasonings, you would want to, especially if your patient is trying to quit, you're going to start with some diagnostics. You're going to get a urine sample. We're going to measure carbon monoxide in the bloodstream. And in terms of management, this is so important, and you're going to read about this in the article that's posted in your module. But the 5 A's of smoking cessation and in terms of the healthcare provider educating include ask, advise, assess, assist, and arrange. Those are the things that you're going to consistently talk about at every visit with any of your patients who do suffer from smoking or are trying to quit. There are smoking cessation programs that you should be aware of so that you can give that information out to your patients. Things such as hypnosis and aversion conditioning are options. Acupuncture is also a very effective thing that some people respond very well to. And one of the biggest things that the USPSTF does talk about in terms of being the most effective is nicotine replacement therapy. We want to discuss smoking cessation at every patient with visits who are smokers. And you can consider prescribing nicotine gum or nicotine patches. Another medication that's very helpful is bupropion or Zyban, which decreases cravings to smoke. Patients can still smoke while they're on bupropion, and it can be also combined with other nicotine products. Usually when patients are taking bupropion, they eventually lose the desire to smoke, and then they end up finally quitting. Although it is contraindicated in certain patients with seizure disorders or any kind of history of anorexia or bulimia or alcohol issues. Chantix therapy is also another option, but you have to be very careful with Chantix. It's a therapy that a patient would take for about 12 weeks or longer. It also helps reduce cravings for tobacco use and facilitates quitting. However, these patients with any kind of psychiatric history, you have to be very careful and avoid prescribing Chantix to them, especially if they have any kind of instability or depression or suicidal issues, because that can exacerbate psychiatric disorders. So be very careful with Chantix. E-cigarettes, are devices that heat the liquid into an aerosol vapor, and they come in like different flavors now. And they're really, they are also put patients at very high risk for lung cancer as well. So in terms of smoking cessation, again, they have guidelines from the CDC and the USPSTF right on the CDC website, and I downloaded them for you. There are plenty of teaching tools for healthcare practitioners to provide to their patients, as well as to educate healthcare practitioners and the steps and overview and clinical interventions that the CDC is recommending for these patients. So the CDC has tons of resources. You're going to keep that as a bookmark in your practice, because those resources you should definitely upload or download, print, and have in your office for your patients to provide to them, as well as the practitioners in your office, so they have quick access to it. Again, you're going to need to read the posted article, the interventions for tobacco smoking cessation in adults, including pregnant persons. Like I said before, there will be questions on your quiz regarding it. And in your module, you can see these beautiful CDC teaching tools that you can upload right from the CDC and have. Here they are talking about ask, advise, assess, assist, arrange. Those are the 5 A's that you need to remember in terms of guiding your patients to quit smoking. Remember that, please. Okay, pulmonary function tests. I wanted to get into this. So important because all of your patients with any kind of respiratory concerns will be undergoing these types of tests. The likelihood is, if they need this, you have already referred them to a pulmonologist, although you could be doing this in your primary care practice before they even go. It is a gold standard test for asthma and COPD. So again, gold standard test, meaning that is evidence-based practice, and that is one of the tests that are required for any of your patients with asthma and COPD is pulmonary function testing, both pre and post bronchodilator. This measures the obstructive versus restrictive dysfunction in these particular patients. So what does that mean? We need to review obstructive disorders versus restrictive. So keep in mind, in terms of obstructive disorders, this is characterized by a reduction in airflow, where the patient experiences shortness of breath as they are exhaling air. So they're having trouble getting the air out. There is an obstruction. So what happens if they can't get the air out? That means the air remains inside the lung after full expiration. So obstructive disorders are seen in COPD, asthma, and bronchiectasis, versus restrictive disorders, which are characterized by a reduction in lung volume. So in restrictive disorders, the patient has difficulty taking air inside the lung. So if they have difficulty taking air inside the lung, it's due because of the stiffness inside the lung tissue or chest wall cavity. So your restrictive disorders are considered your interstitial lung disease, scoliosis, neuromuscular causes, and marked obesity. So again, your pulmonary function test is specifically for your asthma and your COPD. So here we go again. So remember, in terms of coding, if you had to code your spirometry, your CPT code, it would be 94010. Now you don't need to know the number, but you do need to realize the importance of coding this particular test, because again, it's a test, and therefore it's going to be give your visit a higher acuity and more reimbursement, as it should. So pulmonary function test is a physiological test that measures how well a person inhales and exhales volumes of air based on time. Spirometry is a simple test to measure how much volume and how fast the airflow moves in and out of the lungs. Through routine spirometry, lung diseases can often be diagnosed in early stages when treatment is most effective. Spirometry is, through routine spirometry, lung diseases can be diagnosed in the early stages, and then this spirometry is used to establish a baseline of the lung function, evaluate the dyspnea, detect pulmonary disease, monitor effects of therapies used to treat respiratory disease, evaluate the respiratory impairment, evaluate operative risk, and perform surveillance for occupational related lung disease. So that's a lot in this little test. And this little test is very important because it gives you a lot of information in terms of the status of where your patient is at in terms of their breathing. So the spirometer calculates and records 3 results. Three results. So it records the forced expiratory volume, FEV1. Okay, so that's up here, FEV1. And that is a person's airflow rate, or the volume exhaled out within the first second after full inspiration. This indicates whether or not there is an airway obstruction. So normal is 3 to 5 liters, or 80 to 120%, 120%. Then we have our forced vital capacity, or our FVC. That is the total volume air forced out of the lungs. So the FEV1 and the FVC are a calculated ratio to diagnose obstructive versus restrictive lung disease. So this is a calculated ratio. Normal values are approximately 80%. Defects in lung capacity include restrictive defects and obstructive defects. And here they are in this little chart. So obstructive causes would be from bronchial spasms, airway inflammation, asthma, acute bronchitis, emphysema, versus restrictive would be caused by, again, obesity, pregnancy, pleural tumors, lung resection, CHF, and severe obstructive lung disease. So the severity of reductions in the FVC and or the FEV1 can be characterized by the following scale. So mild would be 70 to 79% of predicted. Moderate would be 60 to 69% of predicted. Moderately severe would be 50 to 59% of predicted. Severe would be 35 to 49% of predicted, and very severe would be less than 35% of predicted. So your numbers, as they go down, it's the increases in severity of a reduction of lung function. So just keep that in mind. Very severe is less than 35% of predicted. So that's bad. So we have pulmonary function tests and we have pulmonary stress tests. So a pulmonary stress test is a 6-minute walk or stationary bicycle test that is useful to evaluate a patient with symptoms of shortness of breath or wheezing that occurs only when exercising. If a paradoxal vocal cord motion or some other pathology, such as a laryngomalacia, is suspected, an ENT evaluation would then be warranted. But in terms of measuring their response to medical interventions, this is a really good test, especially for patients with heart or lung disease. And it really just evaluates their level of shortness of breath and their ability to function pulmonary-wise in the midst of whatever disease they have. So again, in terms of, once during the initial evaluation, and then once following therapeutic intervention, that's how they determine whether the patient has experienced a significant improvement in functional status with this pulmonary stress test. And in terms of interpreting it, a lower score, which reflects less distance covered in 6 minutes, indicates worse function, versus a higher score reflects more distance covered in 6 minutes, indicates an improved function. There are contradictions or contraindications to pulmonary stress tests. So please keep that in mind. There are absolute contraindications with any patients who have tachycardia or heart rate of more than 120 beats a minute, aortic stenosis, uncontrolled hypertension, uncontrolled asthma, unstable angina, or a heart attack within the last month. So, I mean, these are pretty basic contraindications. Like, of course, if the patient can't breathe or has a very, very fast heart rate, you're not going to give them a test that's going to give them more stress, right? But to just want to make sure that you make sure the patient doesn't have any of these factors before they are referred for a pulmonary stress test. Now, you think that you would already know that, but just keep that in mind, because sometimes a pulmonologist will refer that your patient for a pulmonary stress test, not realizing that they might have had any of these particular things going on with them. So again, you're playing primary provider in your role in a primary care practice. That's one of the things you need to be, just looking out your patients for, just to intervene if necessary. And in terms of the pulmonary stress test, they're looking at the Borg scale of perceived exertion. Just be familiar with the Borg scale. This is just how they rate the dyspnea, or the levels of dyspnea. Okay, interpreting chest x-rays. So again, we're going to really get into this next week. The most important thing I really wanted to point out this week, just to give you the heads up, is the very basics of how to interpret a chest x-ray. And so the most important thing is you have to read a chest x-ray systematically. But the first thing you need to do is be familiar with what the regular anatomy already looks like. So you have to be very, very clear as what the regular anatomy looks like in a chest x-ray, because you're going to systematically say, oh, okay, here's the trachea. I know the trachea is midline, so that's normal. There's no air beneath the diaphragm. I already know that's normal. The heart occupies less than half, so I know that's normal. The right diaphragm is slightly higher than the left, so I know that's normal. Again, these are the normal findings you're going to see in a chest x-ray. So you need to know what's normal, so when you're looking at a chest x-ray, you can easily point out or spot what's abnormal. You want to know clearly all of these particular anatomical parts of your x-ray, I'm sorry. So we have our aortic knob, which is clearly defined. We have our heart borders, which are sharply defined, normal. We have our costophrenic angle, very sharp. We need that to be sharp. Our heart borders are sharply defined on this side as well, okay? We want to see minor fissure faintly visible, which they are. And then pulmonary vascular markings are less prominent, but present in pieces. And then, of course, very important, your trachea is midline. So if your trachea was not midline, you want to just keep in mind that it's supposed to be midline and be in between the right and left clavicular heads, which they are, which it is, but any deviation from the midline could suggest that the patient was either rotated at the time of the chest radiograph, that there's a presence of a mediastinal mass, or there's a presence of a tension pneumothorax. So keep in mind, if that trachea is displaced, you need to make sure that that x-ray is accurate, like it was clearly done, or we have a major problem, okay? Again, here's some more pictures of just recognizing the basic bones that are visible in your chest x-ray, which includes the clavicles, the ribs, the scapula, the spine, and the proximal humeri. The sternum is also included on the frontal view, but it overlies midline structures, and so it can be a little obscured. So remember, your bones are your useful markers of chest radiographic quality. So you also want to make sure, was the x-ray done well? Like, was the patient positioned appropriately? Were they able to get a full, clear picture, or is it skewed because the patient's positioning was wrong? You have to make sure that that's not the case, because then you could be misdiagnosing because of that. Keep in mind as well, I don't want you to get freaked out that you're suddenly going to have to be radiologist interpreting chest x-rays. That's not the key here. The key is just to recognize a few major things when you are able to, when you do have the opportunity to be asked to read x-rays. So the likelihood is you won't have to. The likelihood is your x-rays are going to be read by a radiologist, and you're going to get interpretations, and you're going to use those results for your your clinicals. However, if there's a night where an x-ray is ordered and you're in an urgent care center or an ER and there's nobody there to interpret it, and you really need to know stat what's going on with your patient, there are, again, certain x-rays that you should be able to recognize just offhand, whether it's pneumonia or a pleural effusion. Those are some major things that I want you to be very aware of. So things that I would like for you to be conscious of making sure you are familiar with in terms of x-rays are emphysema, pneumonia, TB, left ventricular hypertrophy, and a silhouette sign. Those are some abnormal conditions that you really should be familiar with on an x-ray. And they do give you pictures or x-ray films on the exam, like 1 or 2 questions I remember having online, but they can put that on the exam and ask you to interpret them. Okay, please watch the videos in your module to help really get you some firm visual demonstration of how he goes through and systematically reviews x-rays. He did a great job on those videos. So next week, our focus in the second part of our pulmonary module will be asthma, COPD, a little bit more about chest x-rays. In terms of asthma, COPD, sleep apnea, tuberculosis, all of them, interstitial lung disease and lung cancer, I'm going to focus more on treatment and diagnostics for those particular disease processes. I'm also going to get into COVID next week as well. We'll review the most updated info based on CDC guidelines. All right, guys, I hope this was good. I hope you have a great week and you're studying hard and clinicals are going well for you. Please, if you have any questions, don't hesitate to email me, or email me if you would like to set up a Zoom meet, if there's anything you wanted to go over. Again, I'll be going over the coding quiz this week to review that, and we'll just keep reviewing it as much as we need to so you guys feel comfortable with it. Again, that is for life, and I really want you to leave this class feeling confident in just understanding the concepts of coding. Again, I'm going to just repeat this. I don't know if I mentioned this before, but I just feel it's important to tell you that, no matter where you work, every place will have its own methodology and software in place for their coding. So, you may not have to write out as much as you're expected to with, like we did on our quiz, because a lot of it will be pre-filtered where you're checking off stuff. However, you still need to understand the concepts behind what your documentation should still entail in order to validate low, moderate, or high acuity visits. Okay, so have a great week, guys, and we will do pulmonary part 2 next week.